Thanks, Jim, for that really kind introduction. And I also want to thank Dr. Gellerman and NetRF for sponsoring this event. It follows, as you just heard, the two-day NANETS conference, which was a really wonderful meeting where hundreds of people came together to discuss the care of patients with neuroendocrine tumor, where we're moving with research in the field. And it's really very nice to continue that dialogue with you. So I also want to thank you for joining us here today. I'm going to focus my talk on just a very broad overview of neuroendocrine tumors. I think it's always, just like with everything, important to lay the foundation to help us understand perhaps some of the following talks about treatment of neuroendocrine tumors and research into neuroendocrine tumors that'll dive deeper into what I'll be discussing. So the outline for my talk is to focus on really what are neuroendocrine neoplasms or abnormal growths and what makes them unique. What are the key features of neuroendocrine tumors that guide our management? And some of these factors include where the primary tumor started, some of the pathological features that I'll go into in detail, and whether or not these tumors are secreting hormones, i.e. what is the functional status of the tumor. And then I'll end with a brief overview of treatment options for neuroendocrine tumors. So I want to start first with some words about the history of neuroendocrine tumors. And this concept of neuroendocrine tumor dates back to 1907 when a German pathologist, Dr. Oberndorfer, first described these very special tumors that he called carcinoid tumors because he noted that they had slow, somewhat indolent, and what he thought at the time to be benign behavior. And this terminology later developed into what people were calling carcinoid tumors. Over the years, we've recognized that neuroendocrine tumors are much more complicated and that they're much more heterogeneous. They do arise from cells throughout the diffuse neuroendocrine tumor system, and they're called neuroendocrine because they receive neuronal input, just like nerves, and they also can secrete hormones, just like endocrine cells. But they're not always benign. They can grow abnormally and they can also spread, which defines them as malignancies. But compared with other types of cancers, they can pursue a course that is sometimes more indolent or slow growing than other types of cancers. They're also notable for their ability to secrete hormones that can, in some patients, lead to very characteristic symptoms and syndromes. One of the other really important features of neuroendocrine tumors is the presence of what are called somatostatin receptors. And somatostatin is a hormone that we all have that is a master hormone that helps to regulate the endocrine system and also hormone secretion. And what we've realized is that these somatostatin receptors are present on the vast majority, over 80% of most neuroendocrine tumors. And that really can be leveraged for imaging and finding neuroendocrine tumors as well as for treatment, as I'll go into a little bit later and as you'll hear from some of the other speakers in the conference. I do want to point out that this terminology can be very confusing, even to medical professionals, and I'm sure also to patients and caregivers, because you'll hear them, these neuroendocrine tumors referred to as carcinoid, neuroendocrine tumor, and neuroendocrine carcinoma, and there is some overlap, but there are also important distinctions. I do want to note that this terminology carcinoid is falling out of favor because, as I mentioned to you, although initially they were called carcinoid because they were felt to be carcinoma-like, not necessarily malignant, we do realize now that they can grow and they can spread. So most of at least in most organ systems, these neuroendocrine tumors, we're no longer calling carcinoid tumors and really referring to them as either neuroendocrine tumor or neuroendocrine carcinoma. And I'll go into that distinction in a little bit. You know, we will still use the word carcinoid in some instances. There are some neuroendocrine tumors that still, just by definition, are called carcinoid. The most important example of that is lung neuroendocrine tumors, which are still based on the pathologic classifications distinguished between carcinoid and atypical carcinoid. And we also will still call some of the hormone syndromes, most classically carcinoid syndrome. That's a defined syndrome and based on hormone secretion. I want to next focus on some of the really important features of neuroendocrine tumors that I think are important to understand and that really do influence management. And helps us to understand the biology of the cancer. And these are kind of, I've bucketed into four main categories. One is, what is the primary tumor site? Where did the tumor originate? And most commonly, we distinguish between neuroendocrine tumors that start in the pancreas versus neuroendocrine tumors that start in other sites, including the GI tract, the lung, and the thymus. The next important feature really is the stage. How extensive is the disease? Is it still localized or has it spread somewhere else in the body? The other important feature is really the pathology, what we are seeing in a biopsy. And I'll, again, go into more detail, but grade and differentiation are the key elements to focus on. Finally, what we also refer to as the functional status is important to understand. And this is really a clinical diagnosis based on whether patients have symptoms that are related to the hormones that the tumors are secreting. So I'll delve into more detail into each of these, starting first with the primary site of neuroendocrine tumors. And they really can originate anywhere in the body. The neuroendocrine system is present in all organ systems. So we do see neuroendocrine tumors originating in multiple organs, most commonly in the small intestine, in the lung, and in the pancreas. Classically, neuroendocrine tumors were classified based on where they started in relation to the embryologic gut. During development, there's a tube that begins to differentiate into various organs, and the foregut gives rise to organs including the thymus, the lung, the esophagus, and the upper small intestine and the stomach. The midgut gives rise to the small intestine and the first portion of the colon, and the hindgut gives rise to kind of the lower, what we call the distal colon and the rectum. We still will distinguish neuroendocrine tumors based on where they start with these distinctions of foregut, midgut, hindgut. And it really does matter where these tumors start. And the most important reason it matters is because that the biology of neuroendocrine tumors varies based on where it starts. When scientists have done a sequencing analysis of neuroendocrine tumors starting in the small intestine compared to pancreas, we're finding very different genetic alterations. We also see that even stage for stage, neuroendocrine tumors that start in some organs, for instance, the small intestine, behave in a slower growing fashion than other neuroendocrine tumors, for instance, that may start in the pancreas or the lung. And also, most importantly, the treatment sensitivity also varies depending on where the primary tumor originated. Pathology is also really important, as I mentioned, and one of the key elements that pathologists will comment on when they look at a biopsy is something that we call differentiation. And differentiation is what what they're referring to is how similar or dissimilar neuroendocrine tumors appear compared to their normal neuroendocrine cell counterparts. And what I've shown on this slide is an example on the left of what pathologists see as a well-differentiated neuroendocrine tumor, in contrast on the right side to a poorly differentiated neuroendocrine carcinoma. And the well-differentiated neuroendocrine tumors look more similar just by morphology or appearance compared to the poorly differentiated neuroendocrine carcinomas. Pathologists also will use stains to help them identify, not just by appearance, but stains to help them identify that these are originating from neuroendocrine cells. The most common stains that are used are for neuroendocrine markers, including chromogranin and synaptophysin. So those are things that we look for in our pathology reports, the differentiation and the presence of these markers. Grade is also commented on by the pathology, and that's different than differentiation. Grade is really a measure of proliferation, the numbers of cells that appear to be dividing or growing. And the pathologist will assess grade based on, under the microscope, the numbers of cells that are in what we call mitosis, in the process of division, and also a stain for something that's called Ki67, which highlights the cells that are proliferating. And neuroendocrine tumors have been divided into low-grade tumors, intermediate-grade tumors, and high-grade tumors. And they have a very different growth rate and biology based on the grade. I'm going to highlight, and I don't expect you to take notes on this, but I'm going to highlight some of the features that are included in a pathology report. The pathologist will tell us about the differentiation status, And then even divided within that, tell us the grade. So we make distinctions between well-differentiated neuroendocrine tumors that are low, intermediate, and high grade, and poorly differentiated neuroendocrine carcinomas, which are high grade and also by appearance more poorly differentiated. As I mentioned to you, the lung neuroendocrine tumors, they follow a similar principle. The pathologists are looking at morphology, and they're also looking at measures of proliferation. So the pathologists, again, they will assess grade by looking at the mitotic count and other factors that tell us about growth. So these, I think, are for us very important elements to recognize when we first meet patients is, what is the pathology? Because that also helps us to understand perhaps how things may behave in the future and also how we might be able to best treat these tumors. Stage, as I mentioned to you, is based on the extent of disease at the time of diagnosis. Has the tumor spread far from the primary tumor, or is it contained and localized? And this helps us to know whether or not the tumor can or should be removed with surgery. And the stage is determined based on radiology scans that include CAT scans that are done with multiphasic protocols so that the radiologist can take pictures at different time points. MRI is also another imaging modality that we use to assess and to find neuroendocrine tumors. Nuclear imaging has become a very important part of the assessment of neuroendocrine tumors. And as I mentioned to you, neuroendocrine tumors have somatostatin receptors on them in the majority of cases. So we can, or the nuclear medicine doctors can radiolabel these somatostatin analogs that bind to those receptors, and you can image and see the tumors with these nuclear imaging techniques. More recently, we've been using gallium-68 dotatate PET-CT scan, and this really has, in most cases, replaced what had been used in the past with octreotide scan. Another type of nuclear imaging test is a FDG PET scan, and that's a more, I think, traditional type of PET scan that really is looking at metabolic activity. Because many of the lower grade neuroendocrine tumors are not growing or proliferating much, the FDG PET scan may not show those tumors. In contrast, the higher grade tumors, which are growing more quickly, can show up on the FDG PET scans. So what I've shown here is just a few examples of the imaging that we use for part of the staging. A CAT scan on the left, MRI in the middle, and the nuclear imaging gallium-68 dotatate PET-CT scan on the right. And what you can see is that each imaging modality uses a different technique to find the tumors. The CAT scan and the MRI is, just to orient you, these pictures are taken as if somebody is lying on a table, and these pictures are taken with sections. And the radiologist looks at each section to look for areas that might be tumor. So what we're seeing on the, sorry, can you go back one? Oh, this one, okay. So what you can see on the left side is these darker areas this is the liver. You can see darker areas that represent the tumor. In the middle is an example of an MRI from a patient where you can see smaller areas of disease that are in the liver. And on the gallium-68 dotatate PET-CT scan, what we're imaging is looking at a patient face on, and what we're seeing are darker areas that represent the new neuroendocrine tumor because they've taken up the imaging tracer of the gallium-68 dotatate. So when we look at these scans, we stage disease and divide tumors based on their extent. Localized disease has not spread beyond the region of the primary tumor. Liver predominant metastatic disease, the patient may have a tumor that has spread, but has spread only or primarily to the liver. And then there are cases where the disease has spread more widely. And the way that we think about and approach the management of patients really depends on whether it has spread and how it has spread. And I think what you'll hear from some of our other speakers are the surgical approaches that can be taken for localized disease or liver predominant disease, the interventional radiology techniques that also can be used for liver predominant disease. And when there's more widely metastatic disease, we often will be thinking about strategies that will treat the entire body with what we call systemic therapies that are given intravenously or orally. The other important element I think to think about for patients is what we call the functional status. And this really refers to, we use the term functional to refer to whether or not patients have any symptoms related to hormone secretion. So functional tumors are tumors where patients with functional tumors have symptoms that are related to the hormone secretion. And in most cases, what we see actually are non-functional tumors where patients have no symptoms related to hormone secretion. The most classic example of a functional neuroendocrine tumor is what we call the classical carcinoid syndrome. About 20 to 30% of patients with small intestine neuroendocrine tumors have this classic carcinoid syndrome related to secretion of a hormone, hormones including serotonin and other peptides. And the secretion of these hormones can lead to many manifestations, including flushing symptoms, where patients will experience a warmth or a redness, diarrhea. Longer term, the elevation of serotonin and other hormones can lead to complications where there's fibrosis of the heart valve, where carcinoid heart disease may be present, or fibrosis in the abdomen in the mesentery. So other neuroendocrine tumors that arise in the pancreas can secrete different hormones. And what I've listed on this slide are the other hormones that are associated with pancreatic neuroendocrine tumors that include insulin. And due to the excess of insulin, there may be symptoms of low blood sugar. Gastrin, which is a hormone that stimulates the production of acid, so patients may experience symptoms related to ulcer disease. Vasoactive intestinal peptide is a hormone that can cause diarrhea. So I think it's important for us as physicians to understand what types of symptoms patients are experiencing so that we can be able to assess whether or not any of these hormones might be secreted. What's also, I think, interesting to note is that depending on where the tumor started, various hormones are secreted. Some of the lung neuroendocrine tumors secrete another hormone that's called ACTH, which can lead to cortisol excess, which also causes very different symptoms compared to what we see with pancreatic neuroendocrine tumors or small bowel neuroendocrine tumors with the classic carcinoid syndrome. A lot of questions come up about testing for these hormones. We will check for hormones depending on symptoms that patients may be experiencing. And again, depending on whether, for instance, there may be symptoms of low blood sugar, we may be able to check for hormones including insulin. Similarly, when there are other symptoms that may suggest acid production, we can check for hormones like gastrin. And if patients are experiencing bowel movement difficulties or diarrhea, we can check for hormones like vasoactive intestinal peptide. So again, the assessment of these hormones really is dependent on the symptoms that patients may be experiencing. Serotonin, which is secreted by some neuroendocrine tumors to cause that classic carcinoid syndrome, can be measured by checking the breakdown product 5-HIAA that is excreted in the urine. I would say that controversy exists regarding the assessment of other markers like chromogranin A, neuron-specific enolase, or in pancreatic polypeptide. These types of hormones can be made and secreted by the neuroendocrine tumors, but they don't typically cause symptoms. And the use of these markers as part of the follow-up, I think, is something that's debated. So the management principles for patients include resection of localized or limited metastatic disease. And for patients who have more advanced disease, our goals really are to control the symptoms that might be related to hormone secretion if they're present, and also to control the growth of disease. I think it's important to recognize that this is a multidisciplinary team approach, that there are many people who are involved in making the decisions about care, and that can include medical oncologists, gastroenterologists, surgeons, nurses, radiation oncologists. Every patient has a different need, and I think every patient has a different team that's involved in the care of their patients. So I want to start by just giving a basic overview of the options to control the control the growth of advanced, well-differentiated neuroendocrine tumors. And the major categories include surgery to remove localized disease or limited spread of disease. For patients who have liver-predominant disease, we can treat with liver-directed therapies that include ablation or embolization, where things are injected into the liver. And later in the morning, you'll hear from Dr. Sulin about liver-directed therapies. Peptide receptor radionuclide therapy is a newer modality in the United States to treat advanced neuroendocrine tumors that really takes advantage of the somatostatin receptor. And later in the afternoon, there also will be a session about peptide receptor radionuclide therapy. And there also are medical therapies that are used to treat patients with advanced disease that include somatostatin analogs, molecularly targeted therapies, and chemotherapy. So I wanted to give everybody a basic overview of these categories of therapy. So somatostatin analogs are agents that bind to the somatostatin receptors that are present on the neuroendocrine tumors. And this figure is a diagram of a cell that has receptors on its surface. And these receptors are important for integrating signals that help the cells to react to either grow or secrete hormones. The somatostatin receptors are present on the neuroendocrine tumors, and somatostatin analogs, including octreotide and lanreotide, can bind to those receptors. And these agents are used as a therapy for patients because they can improve carcinoid syndrome by decreasing hormone secretion. And they've also been shown to slow the growth of GI and pancreatic neuroendocrine tumors. Peptide receptor radionuclide therapy is a form of therapy where these somatostatin analogs are labeled with a radionuclide that can then find its way to the tumor and emit tumoricidal doses of radiation. So lutetium-177 is one such radionuclide that emits beta and gamma radiation, and lutetium-177 dotatate was approved last year to treat patients with advanced GI and pancreatic neuroendocrine tumors that were growing after somatostatin analog therapy. Molecularly targeted agents are a class of medications that also are used to treat neuroendocrine tumors. And what this figure shows, again, is a cancer cell that has various receptors. And some of these receptors some of these receptors are involved in the signaling that drives cell growth and cell proliferation. There are agents that can bind to those receptors to block that signaling pathway to then block these processes that are responsible for the growth and spread of disease, and also the growth of blood vessels that support this process of growth and spread. So I wanted to focus on one targeted agent called everolimus, which is approved for neuroendocrine tumors. And everolimus is an inhibitor of the mTOR pathway. mTOR signaling is an important pathway that drives growth of neuroendocrine tumors. And everolimus, by blocking this pathway, has been shown to slow growth of pancreatic neuroendocrine tumors, as well as non-functional gastrointestinal and lung neuroendocrine tumors. So this is also an option that we will consider for patients. The other approach to treating cancer is to block this process that's called angiogenesis, which is the formation of new blood vessels that are needed to support the growth and spread of cancer. This process of angiogenesis is driven by growth factors that bind to receptors. VEGF, or vascular endothelial growth factor, is one such growth factor that binds its receptor and that signals growth of blood vessels. There are medications that are called tyrosine kinase inhibitors that can inhibit this receptor to slow down this process. There have been multiple tyrosine kinase inhibitors that have been studied for neuroendocrine tumors. And this is, I know it's a confusing figure, but it lists many of the tyrosine kinase inhibitors that have been studied for neuroendocrine tumors and the receptors that they block. They all, to some degree, block this VEGF receptor, but block other receptors that are involved in growth. We've seen in clinical trials that one of the tyrosine kinase inhibitors, sunitinib, can slow growth of pancreatic neuroendocrine tumors. And there also have been some recent clinical trials that have shown that another tyrosine kinase inhibitor, pazopanib, can slow growth of non-pancreatic neuroendocrine tumors. And just last week we heard that another trial, another phase 3 trial that was conducted in China of a tyrosine kinase inhibitor called surufatinib also slowed growth of non-pancreatic neuroendocrine tumors. There are other trials that are going on evaluating other tyrosine kinase inhibitors called cabozantinib and axitinib. So you may hear about these agents also in the future. Cytotoxic chemotherapy is what many people think of when they think about cancer therapies. They are active in some types of neuroendocrine tumors. Chemotherapy with these types of agents that we call alkylating agents that damage the DNA to prevent growth appear more active in pancreatic neuroendocrine tumors. And the alkylating agents that have been used in pancreatic neuroendocrine tumors include streptozotocin and temozolomide. A regimen that we commonly use is capecitabine and temozolomide, which is effective in patients with pancreatic neuroendocrine tumors. How active these cytotoxic chemotherapies are for patients with other types of neuroendocrine tumors, particularly small intestine neuroendocrine tumor, hasn't been as well studied, but it looks like cytotoxic chemotherapy may not be as active in small bowel neuroendocrine tumors as compared to pancreatic neuroendocrine tumors. So I know I gave you a very broad overview of the different treatments, and I think sometimes one of the harder questions that we ask is, well, what type of treatment? And I think that's, again, where it becomes very important to involve multiple disciplines in that decision. And also, as we make these decisions, we consider various factors that are related to patients, how symptomatic they are from their cancer, whether it be from the cancer and where it is, or whether it's from hormones that are present. We also think about other medical conditions that patients may have as we make our decisions. Some of the disease-related factors are the ones that I had mentioned to you about grading of the cancer and the pathology of the cancer. And I think over time we begin to appreciate how fast or how slow-growing cancers are, and that helps us to determine when we might want to start treatment. I think what you'll hear from some of our other speakers is, one important thing is to think about, is this a cancer that we can remove with surgery, or is this something that has spread beyond the point where surgery is going to be helpful? We look at patterns of spread, for instance, liver-dominant disease, or whether it's more widespread that might trigger us to use a more systemic approach. And then the hormone issues, functional and non-functional tumors also drive whether or not we need to focus on hormone control, starting oftentimes with those somatostatin analogs. We also are very focused on what is our outcome. Are we looking to shrink the cancer, or are we able to stabilize growth where shrinkage is not quite as important? So again, I want to highlight and just let everybody know that this is an evolving field, and treatment choices really must be individualized for each patient. We don't yet have any data that tells us that one treatment is better than the other treatment. We have a growing number of agents that we can consider, but we really need to take into account some of the factors that I mentioned as we make our decision. I want to spend just a few minutes on some of the more rare neuroendocrine tumors because I think they're also important to talk about, and some patients in the audience may have some of these more rare neuroendocrine tumors. So poorly differentiated neuroendocrine carcinomas, as opposed to the neuroendocrine tumors that I focused on, are in most cases more aggressive than the well-differentiated neuroendocrine tumors. They're not usually associated with hormone syndromes, and our treatment is very different because of this biology. We more commonly will start with chemotherapy, with platinum agents and etoposide to treat the poorly differentiated neuroendocrine carcinomas. There's a lot of research going into other types of therapy that may be useful for patients with poorly differentiated neuroendocrine carcinomas, and there's a lot of interest now in immunotherapy. Pheochromocytoma paraganglioma is another rare form of neuroendocrine tumor that's derived from nerve cells in the sympathetic or parasympathetic paraganglia. The adrenal medulla is part of the sympathetic nervous system. These tumors are often benign, but what makes them unique is their ability to secrete hormones, these catecholamines and metanephrines, that can lead to symptoms and medical complications. And what I've listed on this slide is a number of symptoms that patients with pheochromocytoma paraganglioma can experience related to this hormone excess, including headaches, palpitations, diaphoresis, high blood pressure particularly. So our approach to management of pheochromocytoma paraganglioma is to resect these tumors, and it's really important before surgery to make sure that the hormone effects are well blocked with alpha blockers and, if needed, calcium channel blockers or beta blockers. For patients who have more advanced disease, Our goals are still to control the effects of these hormones, to block the effects of the catecholamines, and we also want to, if needed, try to control the growth of the disease. Peptide receptor radionuclide therapy is emerging for the treatment of advanced pheochromocytoma paraganglioma, particularly with the recent approval of iobenguanine I-131, which is a radio-labeled agent that is incorporated into the pheochromocytoma paraganglioma cells to exert a tumoricidal effect. There also is activity of chemotherapy. And there's less data, but sometimes we will use somatostatin analogs to treat pheochromocytoma paraganglioma. There also are reports of activity of the tyrosine kinase inhibitors that I mentioned to you for pheochromocytoma paraganglioma, but this also is an area of ongoing research. So I think some of the challenging questions and future directions are related to appropriate sequence of therapies, and really how can we better personalize therapy for patients in addition to what I mentioned to you, but that are based on disease and patient-related factors. We are actively studying immunotherapy and what the role of immunotherapy might be for neuroendocrine neoplasms. We haven't seen, at least as single agent therapy, as much activity of immunotherapy for the well-differentiated neuroendocrine tumors. We're starting to begin to look at combinations of immunotherapy and immunotherapy with other agents as potentially a way to treat neuroendocrine tumors, but this really is an area of active investigation. I want to end by pointing out that the incidence of neuroendocrine tumors is on the rise in the United States. This is a figure from the cancer registries in the United States, the SEER database, that shows over the last decade or two, the incidence of neuroendocrine tumors is rising across all sites throughout the lung and the GI tract. But what this database also shows us is that patients are living longer, that patients have better survival for neuroendocrine tumors now compared to even 2000, 2004. And I think that what we think is going on is that as we are understanding this disease better, as we're doing more research to understand the biology of treatment, as we're developing new therapies, we're able to extend the lives of patients. So you'll notice that the improved outcomes for patients really does coincide with when we began to notice and when we began to have availability of some of the newer therapies that I mentioned. So there's active research that's ongoing, and we're hoping to be able to build on this to extend the lives and to extend the quality of life for our patients. So with that, I want to thank you. Thank you for attending, and thanks for your attention.